Hello, my name is Todd. I'm an advanced care paramedic from Queensland Ambulance Service. Today's Exemplar video will be discussing the management of pelvic trauma, demonstrating the placement of a suitable pelvic binder and discussing the concurrent use of the femoral splint in the multi-trauma patient. A recent comprehensive review of the literature has challenged the old pre-hospital principle that a pelvic binder is a packaging device. The new consensus, however, in the 21st century is a pelvic binder is now a vital primary care intervention in the management of major hemorrhage. In the pre-hospital environment, diagnosis of a pelvic fracture can be extremely difficult. In most cases, there is no obvious bleeding and deformities can be difficult to detect. This new outlook on the pelvic binder as a treatment option rather than a packaging device must be accepted and understood by all pre-hospital clinicians to continue to improve patient outcomes. Serious pelvic injuries are associated with high mortality rate as a result of hemorrhage leading to hypovolemia. It is therefore understood that if hemorrhage could be controlled prior to definitive care, that there would be an increase in survival rates. The correlation of control of hemorrhage leading to improved survival has already been seen in the field with the introduction of tourniquets for uncontrolled limb hemorrhage. The obvious difference between the two life-saving traumas is the early recognition. We as primary care clinicians need to work hard to consider life-threatening hemorrhage in the trauma patient where there are nil external signs. The Splint sling has been used by QAS for many years. Their website states that they are the most peer-reviewed, scientifically proven device on the market, which utilised cadaver studies and clinical trials to determine the optimal range of force required to safely and effectively close an unstable pelvic fracture. The standard sizing fits accurately to 98% of the adult population and can remain in place for CT and MRI without interference. The demonstration is a simple three-step method, however, the most vital step prior to placement is to accurately determine the anatomical landmark location. Firstly, remove all objects from the patient's pockets and the pelvic area and cut off all the outer garments and gently position the binder beneath the patient's buttocks. The appropriate anatomical landmark being the buccal in line with the greater trochanters and the symphysis pubis. It is very common for the splint to be placed too high or for it to slip higher during transit. Anecdotally, I have found if I place it a few centimetres lower than my first instinct, that it tends to be in a more anatomical position. With the splint under the patient's buttocks, we have now found the appropriate landmarks. Step one for the placement is to feed the black strap through the buccal, placing the buccal close to the midline, as such. With the assistance of a second person, we are going to firmly pull black and orange loops in opposite directions. Nice and firm until we hear that click. It's not necessary, but it does mean that we have now reached the appropriate compression force. Step 3, maintain that tension and firmly press the black strap onto the Velcro strip. The only difference between sizes is the addition of this adjustable black strap to extend the distance on the extra large splint. The contraindications for the splint include suspected isolated neck of femur fracture or suspected traumatic hip dislocation. Once the splint is applied, it is not to be removed and all diagnostics can be performed whilst in place until surgical intervention. Some notes of interest with the splint is the manufacturers state that it can be used in the heavily pregnant patient. However, no studies have been performed to accurately determine the compression force. However, it can be placed in third trimester trauma where there's a suspected pelvic fracture. Secondly, in a pediatric patient where the size is too large, you may use a vacuum mattress to maintain stability. In the last 2 years, QAS have moved to adapt the use of the CT6 splint, also known as the Carbon Traction Emergency Medical Services Traction Splint. Like pelvic fractures, femur fractures can result in hypovolemic shock and potential blood loss between 1 to 1.5 litres within the femoral cavity from a closed femur fracture, and possible exsanguination with compound fractures. Application of the traction allows for reduced hemorrhage, reduction in pain and muscle spasms, assists in immobilization of the limb, preventing further injury. It is also important that effective analgesia is used prior to the reduction of the limb. The indication for use of the femoral traction splint is a mid-shaft femur fracture. The contraindications are a fracture dislocation of the knee or the ankle. In the setting of a patient with a suspected pelvic injury, the pelvic binder is to be applied first to create stability, followed by the application of the CT6. Ongoing assessment with these patients is paramount when you're using both splints. Thorough assessment of hemodynamics, as both injuries can potentiate hypovolemic shock and should be managed as per uncontrolled hemorrhage guidelines with appropriate fluid management and appropriate vasopressors. The appropriate positioning and tensioning of both devices, as you can see on the SAM splint, there are 2 holes on either side. Take note of which ones they're plugged into so that if there was to be any movement during transit, we don't have any displacement. Analgesia, both splints are very painful on application and can be uncomfortable when in situ, therefore continuous use of analgesic where appropriate. Neurovascular status is the most important. Continual reassessment of your neurovasculars, including warmth, pulses, cap refill, and colour and temperature, are important, as well as continual assessment of sensory and motor function where appropriate of the poorly perfused limb. Any compromise in these neurovascular observations is an emergency and requires a major trauma centre and capabilities and pre-notification for a surgical definitive care. Consideration should also be given for the potential injuries that are hidden, as they can be distracting the patient. This is very important in your initial assessment, spinal assessment. Spinal immobilization should be considered as part of your head to toe, with the pelvis or femur being a distracting injury. In conclusion, no longer is the pelvic binder a nice piece of apparel in the well-packaged patient. We understand its importance, and now we will use it for its intended purpose as a hemorrhage arresting, life-saving device. It's important to note that the indication currently in QAS is for the pelvic binder to be placed only where there is hemodynamic compromise. I suggest, as a clinician, we use a case-by-case assessment of our patients, and I believe that as part of our primary survey, arresting an obvious external hemorrhage is considered best practice. I believe arresting an internal hemorrhage should also be. Thank you for watching.